Okay, well, we'll just get started here. My name is Alan Clark. I'm the Regional Knowledge Coordinator for Mental Health and Substance Use. And today's presentation is on changes in the DSM-5, particularly as they relate to the work of an ACS clinician. And so we're doing a number of these presentations, and there's a lot of things in the DSM-5 and changes. Very few are, radical changes, but there's a lot, and so it seemed to make more sense to kind of present it, the information kind of team by team. So we're doing this top 10 series. We're also doing an expert series where we're having some of our psychiatric leadership do presentations on particular disorders and go into a lot more depth with those disorders. So the focus for today is looking at the relevancy of the DSM-5 as it relates to working with the seriously and persistently ill client. And so a particular focus on the Schizophrenia Spectrum Disorders and the Bipolar Disorders and some of the changes in the DSM-5. So, 1 out of 10, the DSM is important. I think sometimes we look at the DSM as kind of medical or a kind of thing that the doctors do. But I think it has a lot of relevance to the work that we do. I think, it goes without saying that a good quality treatment plan requires a good quality assessment. And a big piece of that assessment is the clinical impression, the diagnostic impression. And so, it's our belief that in order to have a good solid treatment plan, it needs to be tied into a good understanding of the diagnostic issues for that individual. Of course, there's more to assessment than just diagnosis, but it gets us pointed in the right direction. I think the DSM also helps us, separate out what we're seeing and look a little deeper. So, for example, in the world of presentations, you might have an individual who is coming across kind of lethargic, kind of unresponsive, and the first thing that comes to your mind is, oh, well, they're depressed. But the DSM kind of helps us look at things differently, look at differential diagnosis, and that kind of low mood could be something like an early psychosis, some prodromal symptoms of the beginning of a psychotic disorder. And so if we write it off as depression too quickly and we don't look deeper, then treatment is delayed and there's consequences for our clients. Similarly, I think the DSM helps us around issues of comorbidity when there's multiple issues at play, and particularly around concurrent disorders with substance use. Often it's easy to get focused on one particular issue and build our treatment plan around that. And so the DSM helps us kind of look again at that differential diagnosis, comorbid issues. So it gives us depth and quality to our treatment plan. The DSM, of course, is also a communication tool. What it does is it defines the meaning of the words that we use when we talk to each other. So we can talk across disciplines. So if you look at the word schizophrenia and look at it historically, it's a word that's been used to describe many, many things. And so it's only in recent years that the understanding of what schizophrenia is has become narrowed down. And so when we say this person has schizophrenia, we all understand what that means. And the DSM also includes a lot of language about how we describe delusions, how we describe thought disorders, thought processes, and you think of all your mental status language, blunted affect, tangential speech, and the like. So we have a common understanding of what those things mean. The other thing that I think the DSM does is it helps our professions organize information within the literature. So if you want to read up on a particular aspect of a condition, you can use the organization of the DSM to better access literature. That helps inform us, educate us, and again, helps us be better clinicians. Okay, so starting off with probably, the change that many of you are aware of is that DSM-5 has dropped this 5-axis structure to assessment. A couple of reasons for that. is that I think physicians felt that they were out of sync with other areas of medicine, that it was something kind of quirky about psychiatry, and that most areas would just simply list the different disorders. So they got rid of the 5-axis structure. The other issue was kind of this separation between personality disorders and other clinical disorders. It was kind of implied that personality disorders were somehow lesser of a psychiatric disorder. It was almost kind of pejorative around personality disorders. So that didn't seem to make a lot of sense, and so personality disorders and other clinical disorders are kind of seen along the same line. Of course, we can continue to comment on medical conditions within our assessments, but within the MRR, we don't code for that particularly. Axis 4, which is the psychosocial problems, and a lot of non-medical professions liked Axis 4 because often the areas that we're working on are the stressors, issues with housing, issues with finances, and so it was nice to have that in there. In getting rid of Axis 4, they haven't gotten rid of the ability to put this down in your assessment and in your coding. So as you may recall with the DSM-4, there was a category for issues that were the focus of clinical attention, but weren't necessarily psychiatric disorders. So marital problems, for example, or housing, or marital problems, for example, would be coded in there. Psychosocial stressors have been moved into that category. In the DSM-4, it was called V codes. It's now going to be Z codes. And so you can still code for that, and you can still recognize that. The GAF, however, that's now gone. As we all know, there was just problems with the validity of that, and two people assessing the same person would come up with a different number. So they've taken that out. Now, they have put in a proposal to use a functional assessment known as the HUDAS, and we'll talk about that in a second. So here I've listed how a diagnosis would look in the DSM-4 and then within the DSM-5. So instead of having the breakdown of the different axes, you now just kind of list the different diagnoses. Now you'll notice that the number is different, and that's about aligning the DSM-5 better with the International Classification of Diseases, ICD-10. And so the numbering system correlates with that. And so there's a new numbering system that we'll need to get used to. You'll also notice here there's a whole lot of other stuff that's added in here on particularly around schizophrenia. So the DSM-5 gives more room, pays more attention to specifiers, and you can communicate more information about a client with those specifiers. Now, we'll talk a little bit more about this with the psychotic disorders. It's actually a little bit cumbersome, and I'm not sure how much functional utility we'll actually get out of it. But it has some values that's kind of worth taking a look at. So you still list personality disorders, but again, they're not separated by axes. Well, this person's got avoidant personality disorder in the DSM-5, not in the DSM-4. So anyway, and then sort of housing problems. So the Axis 4 thing, as you can see, it's now sort of a Z code. And the psychosocial stressors have a little bit more detail to them. So you define housing problems a little bit more clearly, so there's more options and choices for you. And of course, you can comment on the medical side of things. Okay, so that's what it looks like. So now this is the HUDAS, which is the World Health Organization Disability Assessment Schedule. And so what it does is you evaluate a person in 6 domains: understanding and communication, getting around, self-care, getting along with people, life activities, participation in society. So I think there's about 36 questions. You sit down with the client, and you interview them. So it's not an actual testing process. You don't actually test they're functioning in this. You just do it through a verbal report. So there's probably some limitations because of that. But if you've got good information, then it should be okay. And then, let's see. So there's a bit of a close-up. So it's, 1 to 5 scale of severity in there. And there's a way of scoring it. So it'll be interesting to see, how useful this is to people, whether it becomes incorporated or, has some functional value or not. Okay, new categories. So within, the main task of the DSM is to organize information, organize how we look at categories. So this is a process of what do you group together and what do you separate apart. And so it's, if I go into your house and I pull open your cutlery drawer, we'll see the knives in one place and we'll see the forks in another place and the spoons in a different place. And where do you put the teaspoons and where do you put the soup spoons and where do you put your large stirring spoons and ladles, right? So you probably have some organizational system that has some, helps you out in your activities in the kitchen. I've got up on the screen a picture of somebody with a very nicely organized closet. Looks nothing like how my closet is. But, a person spent a lot of time attending to the detail to have an organized closet. And so we all do this. Professions do that. If you're a chemist, you use the periodic table of the elements. If you're a biologist, you have organizations of plants and animals. Geologists, climatologists, all do this kind of thing. So in the DSM, the question is, what do you group together and what do you separate apart? So in the DSM-4, they had 16 main chapters. In DSM-5, there's now 21. And mostly this is they're separating some things out, kind of saying, yeah, some of this stuff's a little bit different, and we should give it a little bit, give it its own place. The opposite has happened in terms of the number of disorders. It's gone down from 172 disorders to 157. And this is largely because in the DSM-5, they've combined disorders along a philosophy of dimensions or continuum. I think one of the things they've recognized in the DSM-5 is that often psychiatric categories don't have rigid boundaries. There's a lot of overlap between, schizophrenia, schizoaffective disorder, bipolar disorder, depression, anxiety. The boundaries are somewhat fuzzy. And so the DSM-5 is giving more recognition to that. And one of the ways that it's doing is looking at disorders on continuums. When we talk about substance use disorder, for example, they've moved it to kind of a continuum type of evaluation. But we'll take a look at that in a minute. So in terms of the larger categories, bipolar and depressive disorders have been separated into 2 different categories. Anxiety disorders went through a fair bit of change. So there's kind of the core anxiety disorders, panic attacks, agoraphobia. And then OCD and related disorders were pulled out from the anxiety disorders. So now body dysmorphic disorder, hoarding are now in there. And interesting enough, they pulled out PTSD and stress-related disorders. So this is kind of the DSM recognizing social variables in psychiatric presentations. And so PTSD and adjustment disorders are now grouped together. And there's a bunch of others that have been pulled out, but we'll skip over those for the moment. So in terms of new disorders, there's 15 new ones and 2 that have been dropped. So if you highlight hoarding disorders, so I'm sure many of you have worked with clients with hoarding issues. A lot of similarities between that and OCD, and in the DSM-4, it was considered a form of OCD. But they're recognizing that there's some unique features to hoarding that are different than OCD, and so they pulled it out as a separate disorder. Binge eating disorder, same thing with within the eating disorders. A lot of clients were being diagnosed with eating disorders, NOS, and they felt that one of the reasons for that is this particular variation of an eating disorder, where individuals will eat a lot in a short period of time, but not necessarily engage in the purging activities that you would get in a diagnosis of bulimia. And so this creates sort of another diagnostic group. A major neurocognitive disorder with Lewy body disease, that just putting Lewy body disease in that list. The one I really wanted to kind of point out here was the mild neurocognitive disorders. So this is saying that we want to be able to identify individuals that are in the early phases of developing a neurocognitive disorder, or what was being called a dementia. So it's allowing us to kind of recognize that, give it a label, and begin treatment earlier on. The DSM-5 has dropped the category of polysubstance use, and they're wanting us to be a little bit more specific in our identification of the substance use of choice. So as I mentioned, there's a lot more attention to the specifiers to give more information, communicate more to the reader, and we'll get into that schizophrenia one in a bit. The other specifiers, so in the DSM-4 there was a category NOS, so you might say depression, NOS, and that would be used when a person didn't meet the full criteria. They've made it a little bit more specific, so you can kind of either go to other specified, which would refer where you could say, okay, this person doesn't meet the full criteria, but you can then communicate what the reasons are that they don't meet the full criteria. Or you could use unspecified, where you choose not to communicate that. So here's some examples. Other specified depressive disorder, short duration depressive episode, 4 to 13 days. So they don't meet the criteria because they haven't been depressed for 2 weeks, but maybe they're just shy of that, and you want to kind of label that. So anyways, that's there, and we'll come back to this because it kind of gets a little bit relevant when we start looking at some of the MRR coding. No changes to personality disorders. A lot of discussion about this, and in the end, they opted to not make any changes. The one thing is a little bit different, and is some of the personality disorders are being co-located. So they're both in the section on personality disorders, and they're also in other sections. So the two examples of that are Schizotypal, which is now in the Schizophrenia Spectrum Disorders, and Antisocial, which is in with conduct disorders. And the reason for this is the research is pointing to some fairly close associations between schizotypal personality and schizophrenia. That personality type, the difficulty with interpersonal relationships and the kind of magical thinking, eccentric thinking that went along with that, seems to correlate with the development of schizophrenia. Okay. All right, so let's get to the meat of things. Schizophrenia spectrum and other psychotic disorders. Schizophrenia spectrum refers to kind of that spectrum of schizotypal, schizophreniform, schizophrenia, along a spectrum, and then other psychotic disorders that aren't within that spectrum. So not a lot of changes. Of course, the one change being the schizotypal personality being included in the section. But most of the other changes are kind of tweaks in the disorders themselves, but not major. Now, one of the things that's interesting is they've kind of reorganized the approach to the psychotic disorders. So they start off by defining 5 domains. And then based on those domains, different disorders have different sort of structures of those domains. They're kind of laid out in different patterns. So, of course, you guys will be fairly familiar with this: delusions, hallucinations, disorganized thinking, which we largely observe through speech, grossly disorganized or abnormal motor behavior is kind of getting into the catatonic type of stuff, and of course, negative symptoms of limited emotional expression and difficulty engaging in task-oriented activities. So these 5 basic structures are something we want to be assessing. We want to look at them first and then move on to a clinical impression from there. So I've kind of laid out some of the differences here. So schizotypal disorder, it's just been added in, as we've mentioned. Delusional disorder is basically the same. You've got one domain, which is delusions, and you have to have it greater than a month. A little bit of tweaking in that it now includes non-bizarre delusions. It's opening itself up a little bit more into that schizophrenia, schizophreniform area. Brief psychotic disorders, pretty much the same, less than a month. Schizophreniform disorder, which is kind of schizophrenia before you meet the 6-month requirement. And then, of course, schizophrenia. Now, let me just talk a little bit about it. So in DSM-4, so there's two aspects to the diagnosis. One is active symptoms, and then the other is sort of negative symptoms or other domains going on for at least 6 months. So the active symptoms have to be there for at least 1 month, and then the negative or other symptoms for up to 6 months to meet the criteria for schizophrenia. The one change that they've done here is in the DSM-5, they've made a requirement for 2 active symptoms. So your active symptoms are your hallucinations, your delusions, and your thought disorders, or your disorganized thinking. So instead of just 1, now you need 2, and then you need some of the others for 6 months. Okay. So again, not a huge shift, but a little bit of change there. In terms of schizoaffective disorder, many of you know, clients sometimes seem to kind of move in and out of this diagnosis. They'll be diagnosed with a bipolar disorder, and they'll sometimes be diagnosed with schizophrenia, and then feel, oh, they got schizoaffective disorder. And so they wanted to kind of stabilize the diagnosis a bit so that it was more longitudinal in nature. People shouldn't be sort of switching around between that. So a couple of the ways that they did that, or the main way that they did that, is that they said that the majority of the time the person had to be experiencing the mood disturbance side of it. There either had to be the mania or the depression the majority of the time. In the DSM-4, it was a substantial amount of time. But now they're saying it's greater than 50%. So it's saying somebody with schizophrenia can have mood experiences. They can have some hypomania. They can have some depression. They can even have full-blown mania. But if it doesn't become sort of a significantly predominant feature, i.e. 50% of the time, then you don't want to move the diagnosis over into schizoaffective disorder. Course specifiers, just some tweaking in those things. But one of the big changes is the specifier around severity. So as you saw in some of those earlier slides attached to the diagnosis, with comments on the different domains. So they've come up with a chart that you can use to specify this. Now, I do want to start off by saying not quite sure how this is going to kind of fit into kind of day-to-day practice. It's not part of the MRR recording. Technically, the DSM is asking physicians to rate along these continuums, but it may have some useful values for us as we go down this road. So, kind of want everybody to take a look at it. So what it's done is it's identified the 5 domains here, and then it added a few more that are relative. So impaired cognitive condition, and then the mood shifts, depression and mania. And so each one of these is then put on a 0 to 4 scale, and then you rate how severe that domain is. Now, what I like about it is it helps us with sort of the language about talking about severity. So rather than just saying this person has hallucinations or they don't, you can talk about how pressured they are to respond to those hallucinations. And so it gives you sort of this sense of severity, from mild to severe, right? And so so I think it's sort of it's useful in that assessment piece. It's probably a little cumbersome to kind of go through this with every client every time you're doing an assessment. But I think just in terms of learning these domains and how to talk about these domains, it probably has some use that way. So I think that's a discussion for your teams and kind of see where that fits for your practice. Early psychosis. So one of the discussions that's been going on for the last few years is how early can you identify someone who is going to go on and develop schizophrenia. We know that early identification is a significant strategy in preventing long-term disability. The earlier we can get people into treatment, the better the long-term outcome is for them. So we want to be able to identify these individuals as soon as possible in their development. And so what seems to be coming out from the literature and the research, and I think this makes practical sense, is kind of after the fact, after the person develops schizophrenia, we can kind of look back and we can kind of see these prodromal symptoms. But we're not having a really good luck with being able to identify that at the time. So it's a person who's kind of showing this kind of social withdrawal or having difficulty in school. The probability that goes on to become schizophrenia is about the probability of flipping a coin. So we don't want to be misdiagnosing people by diagnosing them too early. We're just not there yet in our knowledge base to do that. Now, they are putting out in the section on proposed areas for further study is this notion of attenuated psychosis syndrome, which is really trying to define what does sort of psychosis look like before it's reached sort of the full criteria. What's kind of like a mild form of hallucinations or delusions, and so it's kind of wrestling with that question. It's not a formal diagnosis yet, but it's in the part on areas for further study. So I think that's kind of where we're at in that discussion. Bipolar and related disorders, again, the basic structure pretty much the same, bipolar 1, bipolar 2, cyclothymia. Dr. McIntyre last week did a good talk on this. We got a recording of it, so once we do a little bit of editing, we'll make that available to everybody. Dr. Weehan, by the way, did a excellent talk as well on schizophrenia, and that one is up, and if you want to watch his presentation on that, you can do that. Okay, so the bipolar was a big issue in the discussions around the DSM-5, and the reason for it is there was a fairly rapid increase in the diagnosis of bipolar disorders since the DSM-4 came out. And so this was of concern, and one area of concern was particularly the diagnosis of bipolar disorder within children. And so there was concern that these were false positives, people were being diagnosed with bipolar, when in fact that they didn't have bipolar. So they did a couple of things there. One was they increased the threshold for a couple of the pieces of it. So for mania, in DSM-4 you just needed elevated mood. Now in DSM-5 you need both elevated mood and increased in activity or energy. So both those are required. Also, the mood disturbance must be for most of the day, I think about early every day. It should be nearly every day. And so the wording of most of the day and nearly every day. So it's, bipolar shouldn't be diagnosed when a person is just having brief mood shifts, but it needs to be most of the day, nearly every day. The other thing they added in is this disruptive mood dysregulation for children and youth. And so when they tracked young people that were being diagnosed with bipolar disorder into adulthood, a large portion of them didn't go on to have bipolar disorder at all. They went on to have depressive disorder or anxiety disorder. And so a diagnosis of bipolar disorder didn't seem to continue on. And I think this is relevant for us because we may see adults who were diagnosed with bipolar in their youth, and so we may want to take a bit of a re-look at their presentation and not just assume that a childhood diagnosis carries over into adulthood. So this disruptive mood dysregulation is really about sort of kind of a lot of emotional explosiveness, temper tantrum type things that are beyond kind of the developmental behaviors, the normal developmental behaviors of a child or youth of that age. The mixed specifier, they kind of played around with that. There used to be in the DSM-4 a mixed episode. It's now been converted to a specifier. And they've kind of done some tweaking on the criteria of that. But it has good relevance. They're finding out that as a trait, it's relevant to lithium response in mania and the use of antidepressants and development of bipolar with depression. Now, I think you've all seen situations where a person is in a depressed phase and they're treated with antidepressants, and then they go on to become manic or hypomanic or manic. And sort of this thing of the medication is kind of slingshotting them into the opposite pole of their mood. And so what the DSM-5 is saying on this is, yes, that is a true bipolar disorder. It's more than just the effect of the medication. It may be the medication that's triggering it, but if they didn't have bipolar disorder, they wouldn't have gone into a manic phase. Okay, depressive disorders. So some additions here. We already talked about the disruptive mood dysregulation, so it's located in with depressive disorder, but part of the strategy to decrease the false positive of bipolar disorder. Major depressive disorder, pretty much the same. Persistent depressive disorder is a combining of chronic depression with dysthymia. So the thinking in the DSM group was that dysthymia, because it's long-term, is just as serious as a major depression that may have more symptoms. So as you recall, with the diagnosis of dysthymia, you don't quite meet the criteria for a full depression, but it exists for, this low mood exists for at least 2 years. What they're saying is the duration of the depression is more important than the number of symptoms. So what they've then done is lumped in chronic depression, so people who have long-term depression for at least 2 years with only, with less than a month break in there, in with dysthymia and calling it persistent depressive disorder. What's interesting about this is the research is pointing us in some direction in terms of treatment of depression, that people who are in the early phases of depression or initial episodes of depression, the treatment for them is probably different than the treatment for people who have a chronic ongoing depression. So CBT kind of fits for that early stages of depression, where things like mindfulness may be more useful with long-term depression. So it's kind of, the distinction is kind of helping us point to different kinds of treatments. Premenstrual dysphoria disorder has been on the books for many years, but it's now been officially incorporated as a disorder. Fair bit of requirements here in terms of documenting that. I think it's over a 10-month period that you need to demonstrate it before you make the diagnosis. Now again, specifiers are playing a bigger role with depression. So on the left, I have the 9 criteria you would be looking for a person with depression. 5 is the minimal number that you need to get in order to meet the diagnostic criteria. So mild is, you're at you're at 5 and it's manageable distress. As you go up to moderate to severe, you're looking at getting over 5, and again, the level of stress becoming unmanageable. Now, one of the pieces that's interesting is around the discussion with the bereavement exclusion. In DSM-4, if a person had gone through a major loss, you wouldn't make a diagnosis of depression in the first couple of months. In DSM, they're saying, no, there's a difference between bereavement and depression. Bereavement is feelings of loss related to the loss of the person, but your self-esteem stays intact. You can still have positive feelings. You can still engage in activities of interest. But with depression, it's more pervasive. And you have a lot of negative thoughts around all sorts of areas of your life. You have a lot of self-criticism, self-loathing, and you don't have enjoyment in things that you used to have enjoyment in. So they're saying that these things are different, and so they want us to distinguish between bereavement and depression a little more clearly. And so you can have loss and have a depressive episode at the same time, even in the early days of the loss. And in persistent depressive disorder, we've already talked about. They've added in a specifier for anxious distress, and this can be applied to depression or the bipolar side of things. Again, this is a sort of an example of looking at less rigid boundaries on disorders. Anxiety is often a feature to depression. And what they're saying is that the presence of anxiety suggests higher risk in terms of suicide and poorer outcomes. So being able to sort of identify that may help us be a little more targeted in our treatment. Okay, substance use. So I talked earlier about how with substance use they've gone to more of a continuum, dimensional approach. In the DSM-4, substance abuse and substance dependence were separated into two distinct categories. In DSM-5, they're saying, well, really, that's just sort of an artificial separation. Substance abuse is just kind of a lesser form of substance dependence. So rather than looking at them as distinctly different, they're being placed on a continuum. And so instead, we'll say substance use disorder, and then we'll rate it mild, moderate, or severe. There was also problems with the word dependence, and particularly in the area of pain management. There seemed to be some confusion about how the word dependence was being used, whether that referred to a physiological state of how the body reacts to a substance, including medications, or was it a sort of a broader concept of physical and psychological dependence? So they felt that it was leading to some sort of limits in people receiving treatment around pain because it was sort of being lumped in with this sort of dependence thing. So they kind of moved away from that wording. Now, there I have the 11 criteria for substance use disorder, and I obviously have them in a shortened version. Most of them are pretty much the same as they were in the DSM-4. They've dropped the criteria around legal problems, and this is because sort of legal laws and legal processes are very different across the world, and even across communities. And so you might be more likely to be caught in one community than you would in another, or maybe one person's just lucky and another person's unlucky in terms of being caught. So it didn't really make a lot of sense as an authoritative criteria. But they have replaced it with the concept of craving, and so that's the craving of a substance. And so that has been added in. And it's something that can be observed in brain scans, and so it seems to have a fair bit more utility. So it's been added in. And this is kind of how we rate it. Now, within ACS teams, I know that many of your clients use various substances, and I think statistically they talk about 50% of individuals with bipolar and schizophrenia using substances. But I think on many people's clinical caseloads, they find the number to be much higher. But now you can use this different rating of mild, moderate, severe based on the number of symptoms that a person is presenting with. So mild is 2 or 3 symptoms, moderate 4 or 5, and severe is 6 or more. So you can kind of start thinking about your client group within that continuum. Okay, neurocognitive disorders. Now again, Dr. Ward did a wonderful presentation a couple of weeks ago on neurocognitive disorders, and we have recorded it, and hopefully we will be getting it up and available fairly soon. They've dropped the use of the word dementia. This was in part, there's some kind of stigma attached to it, and also kind of people tended to associate dementia with kind of a stereotypic Alzheimer type of presentation. And dementia is actually a much broader concept. It doesn't necessarily imply memory loss. And so they've gone with neurocognitive disorders instead. And we have delirium, major neurocognitive disorder, and mild neurocognitive disorder. Delirium is pretty much the same. There's some tweaking in the language there, so it's a little bit more specific in the description and a little bit clearer, but the meaning is pretty much the same. Major neurocognitive disorders, so in DSM-4 you would say dementia due to Alzheimer's disease. Now you would say major neurocognitive disorder due to Alzheimer's disease. Mild neurocognitive disorder starts to try and catch people with a lesser level of cognitive decline. So it kind of fits in between people who have a major cognitive disorder and people who have just a normal cognitive decline that goes along with aging. So it's identifying kind of people in an early phase so that treatment can be started off early and we can get on top of it a little quicker. One of the main sort of diagnostic separations between the two is just functional level. So someone with a mild neurocognitive disorder can remain independent. They can still take care of themselves. But with a major neurocognitive disorder, they have lost their independence and are reliant on the care of others. Okay, MRR. This is always our favorite topic. So we'll be switching over to DSM-5 April 1st, so that's coming up pretty quick here. And as far as I know, everything seems to be on track. There will continue to be a separate screen in Meditech for the diagnostic coding in the MRR. As before, you'll be able to put in your standard assessment, or you'll be able to use the standard assessment to do a narrative discussion of diagnosis, but within the separate screen is where you'll do the MRR coding. Instead of 5 axes, you will have room up to 5 diagnoses or impressions, and the hope is that you will rank them from most important on down, so primary, secondary, etc. There will be a text box that you can add in additional information such as specifiers or differential diagnosis or personal comments. Now I don't have any screenshots of kind of how it will look at this point, but this is a screenshot of the lookup. So as before, you'll be able to type in a disorder or just part of a word. Here we've typed in depressed, and it's drawn up all of the disorders that have depression listed in the title. And then from there you can pick, and of course you can see the new numbers that are there. So that should be fairly straightforward. So expect the ICD-10 codes, and don't be afraid to use some of the Z codes for the psychosocial stressors. If you're coding with neurocognitive disorders, just as in the DSM-4, you were to put in the medical diagnosis, such as, say, Alzheimer's disease on axis 3. So the DSM-4 instructed clinicians to do that. The DSM-5 does that. But we don't code on axis 3 or the medical diagnoses. So as with DSM-4, you can just ignore that. Now, one of the areas that we had to do some kind of thinking about is that within the DSM-5 dictionary, they no longer include the category no diagnosis or diagnosis deferred. So this is coming from the APA. The Meditech people created the dictionary based on the APA guidelines, and that's what's been used in our Meditech. So you're no longer going to have the option of doing those two. So that probably makes you kind of pause and think, okay, what am I going to do there? So as we thought about it, it seemed that, well, we need to make, there's kind of a basic assumption that we can make, and is that if we're at the level 3 assessment, then the person's far enough within our system that it should be pretty clear that there's some kind of issue there. You know, mental health or substance use, you know, there should be something present. So the notion that there would be no diagnosis would actually be kind of odd. So if we make that assumption, we can kind of move ahead from there. So what we're hoping is that clinicians will, as much as possible, be able to put in a legitimate clinical impression. And so if you're uncomfortable with doing that, you know, we'd like to encourage you to kind of work on your skills so that you can do that, so you feel comfortable doing that. And I know for some people there's kind of philosophical issues tied to that. So that's something to work through with your team and your team leader. And I'm more than happy to talk with anybody who wants to talk about those kinds of issues, or you know, I can come talk with your team, and you know, we can kind of talk about kind of what the expectations are and kind of the reality in clinical work. I know a number of people, we've had conversations about this. So, but for the most part, we want to, you know, help people get to a level where they feel comfortable entering a disorder. We're feeling that people were overusing the diagnosed deferred boxes previously. So, in some ways, this is a good thing. You can always add the word provisional into the text box. The other thing that you can think about, and you know, there are situations where you're kind of stumped on a clinical impression, or you know you need to spend more time in kind of that assessment phase, and you're just not ready to put down something. And I think, you know, it's you know, a professionally responsible thing to do is to, you know, kind of hold off if that's what the clinical situation calls for. So this is where I think some of these categories of other specified or unspecified might be useful to you. So one of the reasons the DSM created these categories was for situations like emergency rooms where someone was being assessed, and it has to happen fairly rapidly, and maybe the doctor or psychiatrist doesn't feel there's enough information to complete that. So in those situations, you might want to use sort of the label unspecified disorder, but you can capture the category, the basic grouping that they're in. So you might not be quite sure what to say, but you know it's an anxiety disorder, so unspecified anxiety disorder, or you know it's kind of in the depressive category. So it gives you, you know, some opportunity to be a little bit vague, but at the same time passing on useful information. In more sort of desperate situations, I guess, you can always enter kind of a psychosocial stressor, one of the Z codes. And there is a couple of categories, F99, just other, you know, unspecified mental disorder. That's being pretty vague. And so hopefully, you know, you can understand the situation a little bit more than to put that in, but that is an option, or other counseling or consultation is there as well. Okay, 10, last but not least. So we see this transition of, with the DSM-5 as kind of an opportunity for skill development. You know, just kind of a time to kind of focus on the DSM and maybe kind of beef up our knowledge and skill level around it. We've been kind of talking about this transition probably for, well, since the DSM-5 came out in 2013. And from a kind of an organizational view, there's kind of two pieces here. One is just, you know, helping people understand the changes in the DSM-5 and making that transition. But the other is kind of just sort of improving everybody's sort of knowledge and competency in the use of the DSM. So one area is just knowledge. Kind of we work with these disorders, and the more we can know about these disorders, the better. And I think the DSM helps us do that. It's got text information, and learning the language, the wording, you know, helping us communicate with each other, helping us be able to document better. And the other side is just the assessment skill itself. You know, talking with a client, interviewing a client, being able to draw out the symptom presentation, understanding the criteria, assessing for those criteria, and being able to view it within sort of a clinical classification. And one of the things I'm particularly interested in is differential diagnosis. So one of the skills here is being able to ask, a differential diagnosis is when you ask the question, what else could it be? So you're seeing that person, they're you know, low mood, kind of lethargic, inactive, and you're thinking, hey, this is a clear-cut case of depression. But just to be, you know, careful, you start asking the question, what else could it be? You know, would this be something like an early psychosis, or would this be actually a form of dementia, or in early stages of dementia? And so by going through a process of asking the question, what else could it be, and coming up with a differential diagnosis, and then ruling out down to kind of what's the most likely impression, we reduce the probability of error. Our clinical impressions, our clinical diagnoses are better, and consequently our treatment plans are better. So I think there's important skills here to kind of develop. Okay, now let me show you something we've kind of put together here. We put together a DSM resource page. So on the inside net, under clinical care resources, and then mental health and substance use, we have a page of resources. And within education, we have a list of resources from an education perspective. And we have under DSM, and then we have the DSM resource page. And basically, this is a whole bunch of links to resources that are hopefully helpful to you. So there's an electronic version in the library of the DSM. There's video recordings about the DSM-5 changes, APA links for fact sheets or online assessments. And then if I can draw your attention to our expert series videos. So we're posting, here's Dr. Smith talking about eating disorders, and Dr. Weehan talking about the Schizophrenia Spectrum Disorders. So hopefully that page will be of use to you, and I sent that out with the slides this morning. And then I'm hopefully kind of on your teams, you'll do some discussions about, you know, where do you want to go with kind of team development. Okay, I'm going to stop there. I've been kind of yabbling away here nonstop for close to an hour. Thanks for taking time out of your busy day for doing this. I know it's kind of hard to carve out time, and certainly let me know if there's any sort of issues that come up for you around the DSM and the transition, and we can certainly do more talking about that. But thank you very much for joining us today, and have a good afternoon, and have a good Easter as well.